Okay, so tonight our international president, Debbie Kaner-Goldich, could not be with us as she is representing Women's League in Israel on a national leadership mission as delegate to the Conference of Presidents of Major American Jewish Organizations, along with our Women's League Executive Director, Rabbi Ellen Wolintz Fields. It is about 3 a.m. in Israel, so she sends her greetings to all our sisters attending this program tonight. Before I introduce our guest speaker, I want to thank Karen Bellina, the Women's League Member Relations Manager, who is handling all our tech tonight, and I couldn't do this without Karen's help. She helped setting up our registration. I also want to thank Razel Kessler, our amazing Women's League Office Administrator, for her assistance. In addition, I want to give a big thank you to Lori Silverblatt. Lori, wave so everybody can see you. Because without Lori, there would be no program tonight. While we were working on another task for Women's League, Lori mentioned that she knew someone who would be a great speaker for Women's League for Health and Wellness, and would I be interested? And so it is really thanks to her hard work that we have this program tonight. So again, thank you, Lori, for everything you did to help put this program together. When you see your Women's League Week email every week, there are many great programs listed, and these programs are a benefit of your membership in Women's League. And you should note that there is also, because this is health and wellness, there is a resolution on women's health, which has been posted for the last several weeks. And the last day for our members to vote on it is tomorrow, February 25th. So please go back and check your emails for your Women's League Week. If you haven't already voted on that health resolution, that women's health resolution, please go back and vote on it. Votes need to be in by tomorrow. February marks Heart Month in both the United States and Canada. I'm sorry, I couldn't find any data on whether or not Israel has a Heart Month, but in the United States and Canada, it's February. And according to the CDC, only about half of the women in the United States know that the #1 killer of women is heart disease. It's not breast cancer, it's heart disease. And the information is important for us to have and to share about heart disease. So I'm going to introduce you to our speaker for tonight, Dr. Diana Milowitz, who is an MD, PhD, who's done fellowships in both cardiology and medical genetics, a way for the rest of us to feel like we haven't done anything in our lives. She is the President George H.W. Bush Chair of Cardiovascular Medicine, the Director of the Division of Medical Genetics and the John Ritter Research Program, and Vice Chair of the Department of Internal Medicine at McGovern Medical School at the University of Texas Health Science Center at Houston, UT Health. She has received numerous honors and awards for her research and mentoring of physician scientists, including the Doris Duke Distinguished Clinical Scientist Award, the American Heart Association Merit Award, and Rice University Distinguished Alumni Award. She was inducted into the American Society of Clinical Investigation and the Association of American Physicians, AAP, and currently serves as an AAP Council member. Dr. Milowitz is the director of the Medical Scientist Training Program, MD, PhD dual degree program, which is a joint training program between UT Health and the MD Anderson Cancer Center. So Dr. Milowitz is going to give her presentation to us, which I know we're all looking forward to hearing. And then afterwards, there will be a Q&A. Just so you know, during this Q&A, we're not looking for your personal health questions. We're looking for things that are of a general nature that would be of interest to the whole group. So thank you, everybody, for being here. And with that being said, welcome, Dr. Milowitz, and I'll turn it over to you.
Yes, thank you very much, Mindy, for that great presentation. I'm going to go ahead and share my screen for some slides. And tonight, I really wanted to talk to everyone about their risk for cardiovascular disease. Hold on just a second. Sorry, I'm trying to get this to switch out. Just a second. So everybody can see this. I can't get the, does anybody know how to get the banner of Zoom out of the way so I can switch the screens?
Well, we don't see that. We just see the screen, but it's kind of small.
Oh, I can go forward with this. Maybe it'll switch out in a second. Okay, thank you. So tonight I wanted to talk to you about the risk of what I think every woman should know about cardiovascular disease. And this is really taken a lot from information that's provided and generated by the American Heart Association. The American Heart Association spends the money that's donated to support research in cardiovascular disease, but they also spend time getting awareness out to the community, and they bring together world experts in different areas of cardiovascular disease to set the treatment guidelines so that the standard of care is the same no matter where you go, what hospital you walk into, what doctor's office, and that your insurance will cover the standard of care. So I think that Mindy already mentioned this. Cardiovascular disease is the #1 cause of death in women. Right now, the current surveys say that only 44% of women recognize this fact. And basically, a woman dies of heart disease every minute. And that translates into 1 out of 3 women's deaths in the United States are due to heart disease. I'm just going to hit you with these numbers for a while to really convince you this is the case. And that more women die of cardiovascular disease than any other, than all the cancers combined. And that's shown here in this graph. 43% of women die of cardiovascular disease, 22% of cancer, and 35% of other causes. So cardiovascular disease is still by far the major cause of death in the US. Now, if we go back to Mindy mentioned breast cancer, this slide is a little bit old. 1 in 31 women die of breast cancer. And now with the improved therapies for breast cancer, it's now 1 in 39 women that die of breast cancer. Whereas, as I said, 1 in 3 die of cardiovascular disease. So although I think many women think breast cancer is their biggest risk, it's not. It's cardiovascular disease. And this it extends throughout a woman's lifetime. So keep this in mind when you're talking to your kids and your grandchildren, your granddaughters and your daughters. Even at the age of 15 to 24, cardiovascular disease is the major cause. Breast cancer does come up in 25 to 64, but once again, as we get older, it becomes overwhelmingly cardiovascular disease. And this is the risk for cardiovascular disease with the age, where this is the risk going up. And this is the age of the individuals, and men are the blue line and women are the purple line. And you can see that women's risks are a little bit lower than men's when we're younger. But once we go through menopause, which the average age of menopause is 50 years old, the woman's risk increases over a men's risk. The rate of cardiovascular disease actually accelerates in women after menopause. So, and once again, I really want to emphasize that cardiovascular disease affects women of all ages. Cardiovascular disease, #1 cause of death in pregnant women. And remember that all those complications, cardiovascular complications associated with pregnancy, like high blood pressure, preeclampsia, gestational diabetes, even if they go away after pregnancy, they still increase your risk long-term for cardiovascular disease. So what am I talking about when I'm talking about cardiovascular disease? So we're talking about diseases that affect the heart, and that's everything from coronary artery disease to heart failure to problems with the way the heart beats, arrhythmias. But it also includes diseases that affect arteries throughout the body. So the arteries go up into our brain, so that the heart's a pump. And this is just a pump, a pump with pipes. And the arteries, the heart pumps the blood through our arteries, every minute of every day for our entire life. And the arteries take the blood from the heart and send it to all our tissues, so our tissues can survive because they need oxygen. So the cardiovascular disease involves diseases when those arteries aren't functioning correctly. So it includes strokes. It also includes intracranial aneurysms and hypertension. That's another problem with the arteries, where the arteries don't relax enough and we end up with high blood pressure. But the number one cause of all the cardiovascular disease, the number one cause of death in women is coronary artery disease. And I think most of you know that there are arteries that provide blood to the heart so it can pump all the time. And when those arteries get clogged due to plaques, or what we call atherosclerosis, that the blood doesn't go to parts of the heart, and you end up with what's called a heart attack, or a myocardial infarct is the technical term. And it just means that part of the heart didn't get blood, so it didn't get oxygen, and the cells that are doing the work there end up dying. And this plaque that builds up in the artery, the reason it gets clogged is it builds up and starts blocking the flow of blood through that artery. And this is, and it has many, it's referred to in different ways: atherosclerosis, plaques, heart attacks, myocardial infarct. It's all the spectrum of the same disease, where you've got this buildup in your arteries, it gets clogged, and then you have a heart attack. And this is what they're looking at when they do a calcium score. They're looking at how much plaque you have in your arteries in your heart. And that tells us your risk for going on to have a heart attack. So I'm going to number these things that I think every woman should know. First, cardiovascular disease, the major cause of death. Second, doctors can miss cardiovascular disease in women. And many physicians don't even know that women are most likely to die, are as likely to die of cardiovascular disease as men. This was the first time that we realized that women weren't treated the same way as men was way back in the late 80s. And this was the rate of coronary artery disease that goes on to cause heart attack in men and women. And right about here, this is from years 79 to 97. So coronary artery disease common in men and women. And right about the late 80s, we discovered statins. And statins lower cholesterol and change the face of coronary artery disease in the US. And you can see here is that once they had it, all of a sudden the men were not dying of coronary artery disease, but nothing was happening to the women. They were still dying. And they came to realize that the women, they weren't being recognized of having heart attacks, and they weren't being treated with statins. And this was corrected, and there was a big push right about in the late 90s. And but there was a big lag before women saw any benefit from statins until doctors started treating women correctly. And since then, the rates of coronary artery disease have come way down in women. Now, we still have problems. Number 3, you should know that your symptoms, if you have a heart attack, are different from men. And this is the third message I want to get across. Men can have some nausea, vomiting, jaw and neck pain, chest pain, and shortness of breath. But women have a lot more symptoms. They have the nausea, vomiting, the jaw pain, and the chest pain, but they don't always have chest pain. And they tend to have a lot of lower upper stomach and stomach aches, feeling faint, indigestion, and extreme fatigue. So they can present very differently and get diagnosed with psychological problems rather than coronary artery disease. So keep this in mind, because the other thing I want to remind you of Oh, first of all, I want to say that the American Heart realized early on, they were the ones that pushed in the 1990s to get the standard of care the same for men and women in terms of prevention and treatment of heart disease. But they also have really pushed this idea that women's symptoms are different than men's, and doctors have to be able to recognize the different symptoms. And despite all this work that the American Heart and others have been doing, women are still less likely to receive the standard of care, less likely they tend to receive care later than men. In other words, if a man and women enter the ER at the same time, it takes them longer to diagnose a woman, and she gets put on the back burner where the men get treated. And they're treated less aggressively for men. And this is true for coronary artery disease, but it's true for almost every single acute cardiovascular situation. And I'm emphasizing this because I think you have to be aware of this and be your own advocate, or the advocate of you if you go into the ER with your friends or children or other people. The flip side of that is the data also say that women take longer to come into the hospital to receive care. They will wait longer with those symptoms of a stroke or a heart attack. And we see this over and over in the data. So also put that in your mind. If you are having these symptoms, don't wait. Don't say, oh, I need to take care of this person in my family before I take care of myself. Get in there and get taken care of to make sure that your outcome is as good as the men. And finally, I want to say this is something I don't even know how to address. Women are less likely to have CPR started if they collapse than a man, because and it's felt that the bystanders are afraid of inappropriate testing. You got to put your hands on the chest and pump and so on. And this is what's felt to cause this problem. But keep that in mind, learn CPR and be the first one to step up if the woman does collapse. Fourth message, prevention is key. Most cardiac and stroke events can be prevented through education, lifestyle changes, and the proper medications. That means moving more, eating healthier, and managing your blood pressure and cholesterol. And I just want to go through each one of these individually. Okay, first, weight. Know your body mass index, your BMI. And you can go on Google and Google BMI, and you'll put in your height and weight, and it will tell you your BMI. The ideal BMI is between 18 and 25, and that translates to a 5'6" woman of about 140 pounds. If you go higher, up to about 30, you're overweight, and over 30, a BMI over 30 is obese. And if you go lower than 18, then you're underweight, and that's a low BMI. Cardiovascular disease is strongly associated with weight. So the more you weigh, the more you're increasing your risk for cardiovascular disease. And that's just shown here as body mass index goes up, the risk for heart disease goes up also. So this is where you hit the overweight. So no risk being underweight or being slightly overweight. But once you start getting overweight and up to the very, very heavy, your risk goes steadily up. And the American Heart recommends a healthy diet. And I think most of you know this, fruits and vegetables, whole grains, fish, 2 to 3 servings a week, under 450 calories of sugar per week, which I find that almost impossible to maintain, and very low sodium. And the data says that less than 20% of women over the age of 55 actually follow these guidelines for eating healthy. And this is basically that Mediterranean diet that you hear of all the time that fits this exactly. Heavy on fish and whole wheats and fresh fruits and vegetables. And if you start eating that, even if you don't lose weight, you decrease your risk for heart disease. And this just shows that the more you eat fruit, whole grains, fish, and vegetables, the lower your risk for heart disease goes. And the second thing, exercise. You've got to get up and move around. It helps with weight loss. It increases that good cholesterol, HDL. It decreases your blood pressure. And what the ideal amount of exercise that is recommended is 5 times a week, get out and walk fast 30 minutes or ride a bike or swim. So that's 5 times a week for 30 minutes. And I can tell you, exercise is like taking a pill for your cardiovascular health. In fact, when I follow this, I have hypertension myself. If I follow this, I can cut out one of my hypertensive drugs. But if I stop following it, I have to go back on that drug. It truly is like taking a pill. And the data says 7% of women over the age of 55 follow these guidelines. I think that it is such an easy thing to do. And the other thing I want to mention is that there's lots and lots of data that this will improve your mental health, your outlook on life. And so get up and move. And this is just showing you the data. The data is there. This is the amount of activity per week, and that it comes down and then it tends to plateau. So the recommendations are trying to hit this area, that plateau, in terms of the amount of movement. Next risk factor, diabetes. If you have diabetes, it increases your risk for heart disease, and it is helpful to obviously to control the diabetes. And then I want to talk about hypertension. This is a big problem, and it's always been termed sort of the silent killer. If you have blood pressure systolic over 140, you have hypertension, and if you have that measurement 3 times in a row, you need to go on medications. And even being above 120, I think, is too high to make, even if your blood pressure is consistently around 130, you should consider starting blood pressure medications. That as we age, our arteries become stiffer, and in everybody's blood pressure goes up. So as you age, there's more and more people in the population that will have hypertension. So even if you've never had hypertension, I recommend that every 6 months you check your blood pressure and make sure it's checked when you go to see your doctor on a yearly basis, or however often you go in to see him or her, because it's silent. You don't feel it. You don't know your blood pressure is going up. And it increases your risk for a whole bunch of bad outcomes. I just want to mention this: stroke, heart attack, heart failure, all go up when you have high blood pressure. Now you can reduce your blood pressure by lifestyle modifications, and they're exactly what I already talked about. Weight reduction, diet, eating that healthy diet, sodium restriction, physical activity. And this one I can't figure out, but you should only have 1 drink a day to keep your blood pressure down. I'm not sure why that is, but there's clear data to say that if women drink more than 1 glass of alcohol per day, that the blood pressure does go up. So I really, if you have hypertension, please take your medication and monitor your blood pressure. I know many physicians who will not even take care of patients with hypertension unless they have a home blood pressure monitor and check their blood pressure every single day, or at least once or twice a week. And the recommendation is to keep that upper number under 130. For me, I keep it well under 120. And the reason that I do that is because there is more and more data coming out that there's a link of hypertension with your risk for dementia. And this is something that's pretty new. And they have shown that your risk for dementia goes up just completely linear with the blood pressure going up. So if you maintain your blood pressure at 140, your risk goes up. But if you bring it down to 130, it comes down. If you bring it down to 120, it comes down even further. So this is the thing about hypertension is you just don't know unless you're not watching for it, you're not taking care of it, you don't know what it's doing to damage your body, even your mind. And so please take care of your blood pressure. Actually, when I was president of the Texas American Heart Association, we had a surplus of funds, and I put it all into improving hypertension control throughout Texas because this is a major problem. Okay, the last thing I'm going to, 2 more risk factors. Cholesterol, know your numbers. You have a total cholesterol, and if it's above 200, start talking to your doctor about whether you need a statin to lower your blood pressure. LDL is that bad cholesterol. If it goes above 130, think about it. HDL, if it goes below it's actually the flip of LDL. The higher it goes, the better. So if it's below 40, you need to start worrying. It's not so clear that statins will actually raise the good cholesterol. And then triglycerides, there's still a lot of debate, but most people still want to keep them down. Lowering your cholesterol is a little bit tougher than lowering your blood pressure. We don't have very many lifestyle modifications that will lower cholesterol. What you eat really doesn't make that much difference in your cholesterol level. The major thing that determines your cholesterol is who you pick for your mom and dad. It's genetics. And guess what? You can't change that. Exercise has been shown to increase HDL, and if you lose a large amount of weight, your cholesterol will come down, but that's about it. And so if you have those elevated cholesterol, you should be on a statin like Lipitor. And there's now a new drug that if you can't tolerate statins, and some people cannot, there's an inhibitor called a PCSK9 inhibitor. It's actually something that it's almost like diabetes. You have to inject it, but it's only once every 4 to 6 weeks. So it's not the, multiple injections that you need. And statins have changed the outcome of coronary artery disease. I remember when I was young, well into my 20s, that it wasn't unusual that somebody's dad or somebody would drop dead of heart disease, and they'd have no idea they were at risk, and they would just die of a massive MI. You never hear that anymore. And that's because we have statins. That lowering of cholesterol brought down the risk for coronary artery disease, just like I showed you in those graphs. It came tumbling down, first in men, and unfortunately much later in women. But this is a wonder drug that has changed the outlook for coronary artery disease. So right now, these pretty much reflect who we treat with statins. If there's coronary arteries disease, that calcium score is high, we treat. LDLs, it's above 190. But if there's other family history, we may come down on that. Anyone between the 40 and 75 who have diabetes need to be on a statin because of that increased risk for coronary artery disease. And then if you have any of the risk factors that increase your risk for coronary artery disease, you should be on a statin. And statins, the top drug prescribed in the US today is Lipitor. 24 million people in the US are on Lipitor. And that means 1 out of 3 adults are on a drug to control their high lipid. And like I said, it's allowing all of us to live longer. So I'm always amazed when I run into friends that have high cholesterol or one of these risk factors who are not on a statin. Please talk to your doctor if you have this. And smoking, I'm not going to spend a lot of time. I'm hoping that nobody on this Zoom call is a smoker. And the last thing I want to mention is remind you that stress does increase your risk for heart disease. This is, there was the large earthquake a while back, and they were able to show that on the day of the earthquake, the heart attacks actually went up. And here's a study from England, when England's soccer team was playing Argentina, that the day of the match and 2 days after, that the heart attacks were way high and they didn't go down until 4 or 5 days. You know, that stress and excitement can drive heart attacks. And I think all of you know that eating healthy foods, those vegetables and fruits, give you a lot of antioxidants that help decrease, combat the changes in your body that drive stress. Exercise helps decreasing stress, all that yoga, meditation, and if needed, counseling. And finally, just in terms of screening for heart disease, please talk to your doctor. Your doctor should check a risk score for you in terms of heart disease. It takes into account your lipids, your family history, and other factors, and whether you have any symptoms or not. So just in conclusion, you may not look like you have a risk for cardiovascular disease. You may not have the typical symptoms, but you may have a risk for cardiovascular disease. Remember, you need to be your own advocate. And I forgot to add, you know, if you're having symptoms, get to the doctor. If you're slurring your speech, weak on one side, and it might be a stroke, get to the doctor. If you start feeling those symptoms of a heart attack, get to a doctor. If you feel like something has gone wrong and you have pain in your body, call your doctor. And just remember, this is the American Heart Association's Life Simple rule: get active, control cholesterol, eat better, manage your blood pressure, lose weight, reduce blood sugar, diabetes, and stop smoking. That's all we're asking you to do. So that's all I have. I'm happy to take any questions.
All right, so we have some questions in the chat. And so let's see. So one of the questions was, as women, we often just ignore our symptoms. So what stage of pain are we meant to, as the writer put in the chat, freak out about it? After all, it's, you know, a lot of stuff we have and it sort of goes away. So we just assume it's nothing.
I think that if it's sudden onset, and like I said, you know, you can Google the symptoms of a heart attack, the symptoms of a stroke, and look at that and make a decision whether you need to go in.
Okay. So somebody also asked about labile hypertension.
Labile hypertension is actually, I think I have labile hypertension. It's where your blood pressure one day can be low and the next day it's high. Some of that's related to the amount of stress that you have, like the blood pressure will go up with stress and excitement and so on. And sometimes it has to do with your physiology. One thing I don't think people, and it can do a lot with, like, if you, based on what you eat, how much activity you get. Like I said, if I'm doing a lot of activity and following the guidelines, I can take away one of my blood pressure pills. And so if you have labile blood pressure, I think you're kind of stuck just checking your blood pressure a lot. I do that, and I actually sort of adjust up and down my medications to cover my blood pressure. One thing that makes that I wanted to mention is it's a good idea to take your blood pressure in the morning. Our blood pressure stays pretty flat during the day, and then we go to bed and it comes down a little bit. You see, it comes down a little bit, and then right before you wake up, it spikes and then comes back down. And you want that spike is good, but you don't want it going too high. So I recommend to my patients, and what I do is check my blood pressure first thing in the morning. because that is always when my blood pressure is the highest.
All right, so somebody else wants to know about the impact of statins on the liver, and somebody else wants to know about taking CoQ10 with statins.
I don't know if you, I don't think it's a problem, but ask your doctor. I don't know that off the top of my head. In terms, statins can cause some problems with the liver. It often causes pretty severe problems and muscle aches. And like I said, statins came out in the 1980s, and we didn't have another drug until just recent. We had a few other drugs, but they just didn't work as well as statins. And some of them had worse side effects like niacin and so on. Mindy will recognize the names of these drugs. And you never wanted to put anybody on niacin. And, but now we have this Repatha, and it's just a brilliant drug. You inject a small amount under your skin, like I said, about every 4 to 6 weeks. It goes in and actually does what statins do. And it lowers the cholesterol more efficiently, if anything, than statins do. In fact, there's a lot of discussions of even, switching people that need really low cholesterols to these drugs. The bad thing is they're very, very expensive, and it's hard to get the insurance companies to pay for this drug.
I'm sure,
Because
especially now that
it's something you have to be on the rest of your life to prevent.
And Lipitor is generic now, so
It's cheap.
insurance companies are not going to want to transfer from one to the other.
Yeah.
Let's see.
I don't know. Go ahead.
So somebody wants to know about COVID and long COVID affecting women's hearts. But so I would ask a more general question is, what, if any, effects have you seen from the pandemic in general affecting women's heart health?
I think the biggest problem is people are not coming in for their routine care and not coming in if they have heart attacks and strokes. That's been a big problem with COVID, especially early on before the vaccine, because nobody wanted to go to an ER that was filled with COVID for chest pain. and so that has probably that's where we've had the biggest impact. And in terms of the effect on the heart, the major problems with COVID were in the lungs. And I think most people realize that there were short-term and there are long-term problems with the heart. We really do not understand yet how COVID is causing the disease. I think we don't know if the virus is still in there and disrupting the cells, because the virus enters the cells and causes them to lyse. We don't know if when it went into the cells and got released all the stuff that's supposed to stay in the cells, if it has caused autoimmune diseases where suddenly people are making antibodies against those proteins that they shouldn't have seen. And there's some other speculation as to what long COVID is. And I think there's a lot of people working on this condition, and we'll have some answers in a few more shortly. The New York Times just had a great review of our current understanding of long COVID, if you want to look at that and read about it. And especially if you're having symptoms and want to follow what's going on. The last thing I want to say is, if you want to put this in the context of Jewish tradition, I think, how quickly we figured out, what COVID was doing to the body and how to treat it, not only the vaccines, but all of the drugs we have in the regimen, is just amazing and is equivalent to a miracle, in my opinion. I mean, to have that come out so quickly, and I think we'll get long COVID understood and have ways to treat it in hopefully very soon.
So one of the questions was about when should you see a cardiologist for a baseline visit? But I've also started to hear So that was in the chat, but I started to hear some talks about women getting screening EKGs the way they get screening mammograms. So any thoughts about that?
Okay, so an EKG, it's a really simple test. That's where they put the electrodes all the way across your chest. And what they're looking for is that heartbeat to make sure that the heartbeat is regular and everything is working correctly. It does not tell you your risk for coronary artery disease at all. So I think that talk to your doctor. I think if you have a family history of people having coronary artery disease, but when you're definitely by your early 40s, you should be talking to your doctor, if not in your 30s, okay? And then if you have high cholesterol, that 190 number, then you need to get on a statin in your 40s. If you're, in between, 130 and 190, and you're 60 years old or 55, you may want to get that calcium score, because that will tell us if you have any plaque there at all and how much you have. Because then if you go in and you have that sort of borderline cholesterol and they do the calcium scan, and you're postmenopausal and there's nothing there, then you could probably not worry about starting statins right away. So it's really something that you need to work out with your doctor. Remember, there are families that have coronary artery disease that have low cholesterol. So there's other causes of coronary artery disease that can occur in people with normal cholesterol. So that's when I come back to that family history, that if that should be considered also in terms of statins.
Can you speak a little bit more about what the calcium score actually is?
Oh, so it's a scan where they look for, so those plaques that form that I showed in that picture inside the coronary arteries, they actually deposit, it's actually kind of cool what goes on. The cells that go into the plaque, they start thinking they're bone cells, so they start laying down bones. So they get calcium inside the plaque. And so they can just look at how much calcium there is on the scan to see how much plaque there is. And so if it's under 10, no plaque, 10 to something is okay, minimal plaque. But if you get up to the 300 to 400 range, that's a lot of plaque, and they probably need to do further studies to make sure there's no blockage anywhere.
Okay. Would a history of cancer and chemo and radiation affect heart disease?
Yes, it does. And especially if you got a radiation to your heart. So back, like 20 years ago, anybody with Hodgkin's got radiation that involved their heart. Now we do radiation that's much more targeted, but that can damage your heart. The chemotherapy can damage the heart. And so, yes, I think that is something you need to discuss with your doctor.
So what should a woman look for in a good cardiologist?
That's a good question. I think that I think you want somebody that can listen to you and can communicate back to you in ways that you can understand what's going on and explain the treatment to you. And there's excellent cardiologists throughout the country. And like I said, the American Heart, part of their mission is to say, these are the standards of care. This is what every single cardiologist should do when this type of patient walks into their office, so that you don't have to worry so much about one person doing something that's better than somebody else. And as I mentioned at the beginning, number two, that sets the standards of what the insurance company will pay for to cover in terms of your care.
So let's see, a couple of questions about AFib.
Yes.
To talk a little bit about AFib.
So atrial fibrillation is one of those problems with the way the heart beats. So the heart goes lub dub, lub dub, lub dub. And when you have AFib, the lub isn't working right. And it ends up that it's firing, instead of being a nice steady beat, it ends up that it's misfiring and it's firing too much. And so if you take your pulse, if you just put your hands on your pulse here, it should be nice and regular. If you have AFib, it's totally irregular. And the major problem with AFib, well, it does two things. It makes your heart beat too fast, and that can cause you to faint or pass out. But the other thing is, because the heart contracts and it closes off, and when you have AFib, it ends up going like this, especially in one part of the heart, and clots can form there. And so the blood in the heart goes, when it pumps, goes up the aorta and through our body, but it most directly goes up into our brain, and those clots can go into your brain and cause a stroke. And so if you have AFib, you definitely need to be taken care of by a cardiologist to make sure it either stays under control or they do something to limit your risk for forming those clots going to your brain and causing a stroke. And your risk for AFib goes up as you get older, unfortunately.
Is it associated with other heart diseases?
Yeah, quite a few. Anything that kind of damages the heart. And can run in families too.
Yeah, no, I should have picked better parents.
Yeah.
Advice and recommendations frequently change. For a long time, everybody was told they had a history of heart disease to take baby aspirin. Then there was a big to-do not too long ago. Oh, maybe not, we shouldn't do that. We were told, oh, you shouldn't eat eggs. Now we're told, well, eggs maybe not so bad. It really probably
it doesn't matter that much what you eat. I never understood the egg recommendation.
So how do we make sense of all of these changing recommendations that we hear over and over again?
Okay, number one, they are there and they are changed. They change because we want to provide the best standard of care, the best recommendations, and science is not exact. We sometimes you make recommendations because it's based on a consensus that everybody thinks this is doing good. And then you do the studies and it actually isn't doing good. And that's what happened with the baby aspirin. And the hormone replacement after menopause, the Women's Heart Center, the Heart Initiative showed that it was bad, but then when they looked more carefully, maybe it wasn't as bad, and we can do a little bit of hormone replacement for a while right after menopause comes in, and so on. So that the whole idea behind cardiovascular research is always to push the envelope to gather new data, take a look at what you're doing and saying, we can do this better. And here's some new recommendations. And I know it drives you crazy, but it's all that, keep in mind, it's science. And we're just going with the best evidence that we have at that time.
So we have a couple of questions. One is about low oxygen levels causing or influencing cardiac disease.
So people don't often find themselves in low oxygen levels. I think that two things: flying, where you go up high, and then going to a higher altitude will lead to low oxygen. And so let's take flying. They provide extra oxygen, and it's only if you lose pressure that's a problem. But going to higher altitudes is a problem, and it's as you get older, you should make that ascent up into the mountains longer and longer. Okay, so what happens is there's less oxygen in the air, your body has to make more red blood cells to provide oxygen to all your tissues. And that takes usually about 3 days to rev that up. So my 93-year-old parents still go up to our cabin in the mountains but I make them take 5 or 6 days where I slowly take them up 1,000 feet to rev up that red blood cells. And there's protocols on the internet to do that. But you should not go from Houston, where I am, up to Vail at 9,000 feet if you have a heart condition or you're at risk of stroke. And I've seen it over and over again up in the mountains that people do that. They come right up and they end up with something devastating happening. But if you do it slowly and give your body a chance to make more red blood cells, you can do it safely. One thing is, when you go to high altitudes, your blood pressure goes up too. People don't realize that. I have to go on an extra medication when I go up in the mountains.
Is low blood pressure a problem?
Yeah. That means you're not getting that blood to things, and it can cause you to faint and pass out and so on. So and there's also, you don't want your blood pressure going too low at night because it can cause other problems. So low blood pressure is pretty uncommon, but there are some people when they're laying flat and then stand up suddenly will have their blood pressure will drop. And if you have those kind of problems, you just need to get up slower. And drink lots of fluids and talk to your doctor about it.
We have some questions about baby aspirin. One is, should the use of it be limited to a certain period of time? And another question is it baby aspirin or regular aspirin?
It's baby aspirin, the little ones. I forget what the exact
which 81 milligrams, which we don't ever give to babies. That is a big no-no in pediatrics. No aspirin for babies.
I think it was baby because it was small.
Well, actually, there was a time when that was what they gave to babies, but by the time I went into medicine, they had long since stopped that. So, but it's still called baby. And now it's not called. It's called low-dose aspirin. When you go buy it, it's called low-dose aspirin.
There are still some situations where that baby aspirin would be okay, but your doctor should prescribe it in those situations.
So we have another question about home monitoring systems for blood pressure. Like, how do you know that you've gotten a good one? There are a lot of them out there. The reviews online are maybe not so good. How do you know which one to get?
The Walgreens one is really good. That's the one I have. I don't know my blood pressure monitoring kits. Sorry, I don't know that off the top of my head. Hopefully there's some with good reviews, but I know the one that Walgreens makes is fine.
Somebody else wants to know about Nexium and associated medications. I'm not sure in what context. I guess there was some controversy about taking Nexium and other GI medications, but I don't know if that was really cardiac related, the Nexium.
So the issue with PPI inhibitors, is that what that was associated with an increased risk of dementia. And that data is fairly new also. And I know it's led to a lot of people coming off of that type of drug. I personally would have come off of it had I been on it and tried another way to control my indigestion or reflux. So once again, talk to your doctor. There's other drugs like Pepcid and others that don't work by a different way, work through a different mechanism to control reflux. That's not a hard question, guys.
Somebody else wants to know, what are the side effects of the injectable medications, the new medications for cholesterol?
So the side effect is it's expensive, but the only question, it drives the cholesterol so low that people are asking, can it be bad to let your cholesterol go this low? And right now, there's actually people that have genetic diseases that drive their cholesterol as low as it does with the PCSK9, and they live long, healthy lives. So there's, as far as I'm aware, there's no side effects from that. And they're actually trying other type drugs, like they're trying to make it where you get a vaccine and it works the same way as this injectable does. And so so that you only have the vaccine the rest of your life, you'd never have to worry about your cholesterol. So we'll see what happens with all of that. You know, maybe statins will be old medicine in the future.
Just time for another question or two. How often do we see muscle weakness with the statins? Is that
I
common?
don't know that off in my head. I think that so muscle weakness is not that common. Muscle pain is more common. And that I don't know the percentage off the top of my head, but it does occur.
Okay, let's see, scrolling through here. We have a question about Eliquis. Can the heart naturally return to sinus rhythm if somebody's been on Eliquis, and how long would one normally take Eliquis for?
I don't think so. And I think the doctor will determine how long the Eliquis needs to go on.
Okay. So I think this was really terrific. I am so glad that you were here to talk to us tonight and to answer all our questions. I should tell you that my best friend from medical school is an internist, and she drummed it into my head that I have to think about heart disease in women all the time, that it never ever gets enough attention and the attention that it needs. And so even though she is a general internist, she really always has said that to me whenever things come up. She's like, you have to remember this. So this was something that I've really been wanting to do for a long time for our Sisters in Women's League, because I think it's really important that we get this information out to everybody and that they share it with their friends and families. That's why this has been recorded. So it'll be posted to the Women's League website. Karen will take care of that for us. And I thank you so much for giving of your time and your expertise to us.
Yeah, thank you for inviting me. It was a pleasure.